Good morning, everyone. It gives me a great pleasure to introduce Dr. Tiago Machuca to those of you who don't already know him. Tiago is a thoracic surgeon who trained in Brazil and did fellowships with us, both in the Latin Thoracic Research Labs and then in thoracic surgery and lung transplantation. And I must say, I'm most one of Tiago is one of our graduates of which we are most proud of. He has done incredibly well. He took a position at the University of South Florida as an academic thoracic surgeon and in the division of cardiothoracic surgery there. And over time, established himself as an academic surgeon with a research program. But importantly, the lung transplant program, when Tiago arrived at South Florida, was doing about 14 lung transplants a year and actually was on probation for problems with clinical results. And as a young thoracic surgeon trained in Toronto, taking his first job, his job was to turn that program around. And within a year or so, he moved it to doing over 100 lung transplants a year. And if you look at the SRTR and UNOS results, you can see that the University of South Florida now has the top results in the United States in terms of outcomes for lung transplantation that are reported. So a remarkable achievement. And all of you know that lung transplantation is not a one-person sport. And so that means pulling a whole team and an institution and directing resources towards achieving excellence and building a culture of excellence. He's also built their ECMO program, as we have done here, from single digits to I can't even remember whether he's doing 100 a year. And obviously, when COVID hit, their institution was ready to deal with the onslaught of patients requiring ECMO for COVID. The whole issue is, and this is very topical for us, is that when do we find out if the lungs are not recoverable from COVID and the patient might require a lung transplant? And there's a certain fear or trepidation that, you know, we're transplanting everybody that's showing up with COVID. And how do you make these decisions, and how do you allocate lungs fairly to patients on the wait list? And Tiago's program has really been on the leading front in the world. There've just been a few institutions that have done a large number of transplants for COVID. So Tiago, it's a great honor and pleasure to have you back speaking to us, and we look forward to hearing about the indications and outcomes of lung transplant for COVID. Thanks.
Shav, thank you so much for the kind introduction. It is a great honor for me to come back and be able to share a little bit of our experience today with lung transplantation for COVID. There's no doubt that I always remember my Toronto days as the most impactful in my career, and I think I was extremely lucky to have the best mentors that a trainee could have. And I think what I'm going to show you here today is essentially applying the knowledge and the skill set that I learned at University of Toronto, how we were able to create not only a regional, but I think somehow like a national impact. So I think I want to use the first 5 minutes of the talk just explaining why we became the leading institution in the United States for lung transplantation for COVID. That didn't happen from night to day. So as Shaf was alluding, by January 2015, when I joined the University of Florida, this was the actual scenario. So low volume of transplants performed. Then I think what is more concerning, the outcomes were essentially poor. So a 1 year survival of 71% was really putting us on track for quality oversight issues. And I think things have changed a lot. I think that being able to build a team and implement a lot of the things that I learned at University of Toronto, I think we were able to really turn things around. So on the last calendar year, we were on track to do 100 plus lung transplants, but with COVID, by the end of the year, we really had a low number of donors, and with all the testing barriers that you are all aware that have changed recently. I think it was a little bit difficult to use donor lungs, but I think what's more important is if you look on the right side of the figure, you look at the quality added. So we were able to add quality with high volume and reaching a 1 year survival of 98%, which really by the last scientific registry for transplant recipient puts us as the leading center in the country. And I think just looking back, this is where our patients were coming from. So essentially, only regional patients coming from around Gainesville, which sits in central North Florida. But this is this fiscal year. You can see here that the patients are coming obviously from farther and farther away, and this is all related to COVID referrals. Most of them they're coming from out of state, but you really can see that they came from really far away. And obviously for these patients to get all the way here, there were serious let's say insurance discussions and why the patient couldn't be or wouldn't be transplanted at their local center. Most of the times these patients were declined and as they were moving farther away, there were quality issues until we were able to convince that these patients should be coming here and we could perform a successful transplant. And a lot of I think these ability to transplant patients with COVID is related to ECMO. I think that obviously this is how we are supporting these patients when they are maximized on medical therapies. But obviously, I think that the intraoperative aspect, if we were still on the cardiopulmonary bypass days, I think that most of these more complex transplants will be almost like a suicidal mission. So I think I was lucky to be in Toronto when there was this ECMO revolution on the intraoperative aspect of management, and this is the early experience showing how the University of Toronto transitioned from cardiopulmonary bypass to intraoperative ECMO, clearly showing that the perioperative outcomes were superior when you compare that with cardiopulmonary bypass. And this is what we implemented at the University of Toronto. So we truly believe in the use of intraoperative veno-arterial ECMO for lung transplantation. We have still I would say a handful cases of cardiopulmonary bypass that are patients that require any intracardiac repair or any more complex or intraoperative catastrophe that luckily are rare these days. But you can see that we're doing about 85% of transplantation with veno-arterial ECMO these days. And I think that that's what Shaf was alluding. As we were able to bring the ECMO to the OR and get the teams more experienced, we gauged interest from the hospital also to build an adult ECMO program. So before getting there, there were a few scattered cases. We were essentially a pediatric ECMO program, and you can see here that nowadays we're offering ECMO for more adult patients, and this is the great majority of cases. This fiscal year, we crossed 100 cases, and a lot of that is related to the experience with COVID. And then the bridge, right? So we were using ECMO in the intraoperative setup. We were using more ECMO for ARDS, bridge to recovery. And you can see here a stepwise utilization of ECMO as a bridge to transplant that we started with low numbers. And here, a lot of this is related to COVID. You can see that about 10 to 15% of the transplants that we are performing are patients that are bridged with ECMO. And we follow very closely our outcomes. So you can see here that we have a 1 year survival of 88% on patients that make to transplantation. But when we look at the intention to treat aspect, you can see that the survival is 80%, which is still very acceptable. Just if you compare with United States numbers, you can see here that when patients reach transplantation, the 1 year survival tends to be very favorable. But when you start looking at an intention to treat analysis, there's still a huge problem with patients that end up being listed, but they never make to transplantation. So you can see that especially in ILD patients, this is an experience from Colombia, it dropped from 87 to barely 30% 1 year survival when you transition to this intention to treat analysis. And this is what happened over the course of the years at our program. So I think this was very important to put in the context of COVID lung transplantation. So our deaths on the wait list, they went from 33% to 2% on the most current era. And the wait time from our patients dropped from 130 days median to 25 days. So this was implementing a lot of strategies such as being more aggressive and willing to go for more donor lungs that they didn't look perfect, but during the intraoperative evaluation, they indeed were ideal donor lungs, implementing the use of ex vivo lung perfusion, utilization of DCDs, which was barely existent in Florida, and then lastly, using aggressive lung resizing techniques that go all the way to performing lobar transplants to offset the disparity in short stature patients. So here you can see that with all these improvements that we implemented pre-transplantation, so bridging patients when they were on our list and they were on the verge of dying with ECMO, or being more aggressive on the donor end so we could shorten the wait time and improve access to transplantation, but also improving the post-transplant outcomes with a more consistent team, higher utilization of intraoperative ECMO. You can see here an intention to treat analysis on our patients that were listed by 2009, 2015, and now 2016 to 2019. So I think that this is very striking and almost resembles survival curves of a disease that indeed have a cure and they're being treated, in a disease that is left untreated. So just to show here, before going to COVID, we were also increasing the acuity of our patients. You can see here that when we look at the patients that were admitted to our hospital with acute on chronic interstitial lung disease exacerbation, when transplantation was not an option, you can see that virtually all of these patients were dead by 1 or 2 months. And when you look here at our experience with this subset of patients, obviously here understanding the selection bias, but showing that it is possible to achieve excellent outcomes with patients that have chronic interstitial lung disease and they are admitted with an acute exacerbation. You can see that they appear even to not be disadvantaged in terms of survival when you compare to those patients that are coming stable from home to get their transplants done. And just to put that into perspective, in some American statistics, there is a publication from Temple showing that in this situation, the 1 year survival dropped to 71% with a 3 year survival of 60%. So clearly showing that these cases tend to be more complex and the outcomes may be impacted. And then I think this also shows the evolution of our program over the years when we created a dedicated lung unit that now was no longer a cardiothoracic ICU. We improved access to these patients and we were able to transplant patients with more complexity. You can see here patients that were transplanted from the ICU in our program went to 15% to 33%. And then the pandemic came. So you can see here that by December 19, I think that our lives have been changed forever. I think that this pandemic has changed the way that we practice medicine, the way that we see acute respiratory failure, and in fact, the way that we live. On more updated numbers, there's close to 160 million global cases with more than 3 million deaths. So obviously, this is the most pressing issue in our lives right now. And what we know in terms of epidemiology is that 14% of patients that acquire COVID develop severe disease with hypoxemia, and 5% of them become critically ill and they end up being admitted to the ICU on mechanical ventilation. So when the patients go into ventilation, the mortality is high. So it's almost like 50% of mortality, and that changes in terms of patients that are younger or patients that are more on the elderly spectrum, the mortality is higher. And ECMO, even though the early experience was very negative with more than 80% deaths on ECMO when it was utilized and reported by the Wuhan cohorts, what we know nowadays with increasing numbers and more experienced centers is that it is possible, and there is a role for ECMO support for patients with COVID-19 ARDS. However, it changed a little bit the way that we see these runs. So the ECMO runs tend to be significantly longer. So we're not talking about the 7 to 14 day ECMO run. Now we're talking more and more to 21 days or close to a month ECMO run to see recovery on these patients. And obviously, as more ECMO and mechanical ventilation is being utilized, we started to see patients that progress to this unwinnable state. So these are patients that they are functional, they don't have any additional end organ injury, but their lungs never recovered. So these are patients that we consider transplantation. And a lot of these referrals started to come to us by May, June 2019. Obviously, there was very little evidence by the time. There were a couple of case reports coming from China. There was that case from Vienna of the young woman transplanted when she was still not awake, and then the three cases from Northwestern, mostly focusing on pathology findings. So I think that is one aspect that we feel is very, very important in lung transplantation for COVID-19, is that you need to understand that native lung recovery is obviously better than proceeding with a transplantation. So this is a case report that was published in Annals of Surgery in July of last year, and it was very unclear how that these cases became published. I think it was a lot of the COVID hype, but you see that these were elderly patients that were transplanted after being less than 2 weeks on ECMO, and the criteria of determination for end-stage lung disease was the description of white lungs, which obviously, when we treat patients with ARDS on ECMO, I think this is essentially what you see when you transition these patients from high deleterious mechanical ventilation settings to lung rest settings. There's a clear de-recruitment, and the lungs become completely white. These two cases had no follow-up data. It was unclear how access to donors was in such a short time of 2 and 3 days. And then we ended up writing a letter, I think, really stating that we need to focus on bridge to recovery to COVID-19 ARDS. And I think that if you proceed with transplantation, if you pull the trigger early on, you're burning this bridge. So again, patients with less than 14 days of ECMO support, I think that when you list these patients early, you are creating a disservice for them, because they will have to have dramatic lifestyle changes and their life expectancy is going to be impacted versus if they achieved lung recovery. And obviously, you're also having a second hit of negative impact on those patients that, if you will, they're conventional patients, not COVID-19 ARDS, waiting for a very limited resource, which are donor lungs. So I think that in 2021, I think that it is clear to all of us that transplanting patients that have been for a long time on ECMO, that they acquire an acute illness, I think is possible, and it has been proven several times. However, I think the main question here is not if it can be done, but when should it be done? And that's where a lot of the discussions are centered, and I think to me is the most difficult decision-making step. So just to focus on this aspect here, I want to share with you a case that we had on early on our experience of a 47-year-old male. This was a physician treating COVID patients in his hospital, and he developed COVID with a rapid progression to mechanical ventilation. He was treated with proning. He was on maximal support. After 27 days of mechanical ventilation, our program was consulted for consideration of ECMO with a possible bridge to transplant. That program wouldn't consider a patient, but to place a patient on ECMO after 27 days of mechanical ventilation, which I think is somehow reasonable. And we felt that that patient didn't have any clear contraindication to transplantation. So the patient was placed on ECMO and transferred to us. So you can see here what I think what is important is to see that this patient really, after 1 month of mechanical ventilation and being on ECMO, he never really showed signs of a chronic lung disease. So this patient was supported on ECMO. We treated him as we used to treat any patient with ARDS, lung rest settings. And what you can see here is that over a course of 24 days on ECMO, so close to 2 months on acute respiratory failure, we really never pulled the trigger on listing him. We just kept evaluating him daily, and as long as he was showing clinical stability with absence of signs of chronic lung disease, we will keep going as long as we had to. And this patient was able to be decannulated after 24 days on ECMO, and he was weaned from mechanical ventilation just short of 2 months. So he left the hospital to rehab. Today, this patient is more than 6 months uh, after being discharged. He's on room air, he's doing treadmill, he's on a path to close to full recovery, and he's back to work. So just showing the, I think is very important, the decision making to wait until you have clear signs of advanced lung disease or the patient is developing life-threatening complications that are incompatible with long survival. I think until that happens, you should sit tight and continue to manage the patient clinically. And this is a collaborative experience that we put together with other centers that started doing lung transplantation for COVID. So you can see here that the first cases done in the Western world were by May 18. They were simultaneous, done on the same day in Vienna and in Milan. That was followed by the case in Northwestern in June. And then we did our first case in July, followed by a Northern Thoracic Institute in August. So let me share with you our first case. And I think this shows, I think, a little bit of the decision-making aspects and the hesitation and how we came up to making a decision and proceeding with transplantation. So this was a 51-year-old male with no comorbidities that on day 2 of disease, he was admitted to the ICU, intubated, and rapidly support escalated, and he was placed on VV ECMO. This patient was in Texas, San Antonio, and he was having a lot of complications, mostly recurrent pneumothoraces with a residual pleural space. Was having a Chromobacter and MSSA bacteremia episodes, but he was somehow stable. So they were able to keep this patient after 2 weeks of ECMO awake, and the complications were being treated. And even though they were concerning, none of them became life-threatening. He never developed septic shock. And by day 74, when they really pushed and saw no signs of lung recovery, they started considering transplantation as an option and reaching out to potential centers. We evaluated that patient and we tried to do as much as of the early evaluation remotely. We talked to the family, we went over potential barriers, and this patient really had none. So this is when the patient arrived to us, and you can see here that there were signs of clear traction bronchiectasis on both lungs, diffuse. You can see the pleural space, even though it was drained. I think he never really regained a complete full expansion of that right lung. And the patient arrived to us by day 74 with that CT scan and on full ECMO support. So this patient was ambulatory. He was ready to be listed, but for 16 days, we continue to assess him to make sure that we really should proceed with transplantation. We repeated 2 CT scans that showed worsening of the bronchiectatic and early fibrotic changes. ECMO support was still on full ECMO support with no weaning of the amount of ECMO need. So to us, it really became clear that after a multidisciplinary discussion, this patient should be listed for a double lung transplant. And indeed, we listed him, and after 18 days, he underwent a double lung transplant. We had to do a lobar transplant on the right side, so right middle lobe and right lower lobe. There's a lot of retraction of the chest cavity. And on the left side, we did a volume reduction on the cumen, on the apex of the left upper lobe. The transplant was uneventful. So this patient didn't have much of adhesions on the chest wall, and that's, I think, because of the recurrent pneumothoraces. But he did have some low grade empyema that we were able to detect. But after the transplant and full lung expansion, that never really became a problem. He was decannulated on day 2, and after 7 days of ICU and 14 days of hospital stay, he was discharged. So just showing really how a patient that you spent enough time to rehabilitate this patient. He was ambulatory, which is to us is the ideal setup, how the outcome can be favorable. He is now close to 1 year. He's 10 months after transplantation. He is back to home. He is having a normal life. He's playing golf. So that's with a normal PFT. And you can see here, he was supported with a 28 left subclavian crescent that was placed at an outside hospital. He already had a tracheostomy, and this is his most recent chest x-ray. And just a second case here to highlight how over time we started to see more severe cases and started to consider these more severe cases. So this is a recent patient, 56-year-old, that we were referred previously healthy. On day 8, he was admitted to the hospital with hypoxemia and treated with remdesivir and dexamethasone. On day 13, he required mechanical ventilation, and then after 17 days with further deterioration, he was placed on VV ECMO. So here, close to 2 months and a half after the initiation of his disease, there was no signs of lung recovery, and he was started to be considered for lung transplantation. This is what we saw. So I think that a little bit different than the previous patient. I think that to us, when this patient arrived at our hospital, it was clear that the signs of chronic lung disease were so advanced that he should be listed for a transplant. But this patient was not awake. He was kept sedated for a long time. There were a lot of challenges to get the patient to a comfortable awake state. He was definitely not ambulatory. And when came to us, we had a lot of issues. He also had a crescent cannula on the right IJ, a 32 French. And as we started to try to attempt to mobilize the patient more, we started to have issues with breast circulation. And the other aspect is when the patient was more awake, his O2 requirements started to go up, and the cannula was limiting our flows. So on top of that, we were also starting to see signs of right ventricular dysfunction with severe RV dilation, a low TAPSE, and right ventricular systolic pressure estimated in the 80s. So what we elected here, as that was impeding our rehabilitation of this patient, on day 96, we brought this patient to the OR. We started by cannulating him on VV ECMO with 2 cannulas. So you can see here the right IJ crescent. We place a 24 French multifenestrated cannula in the right common femoral vein, and we place 20 French cannula EOPA on the left IJ, and we did that while the patient was still being supported on ECMO. And once we achieved better oxygenation, his signs of RV dysfunction were still there, climbing needs of Mirinon, vasopressin, and worsening echocardiographic signs. So we elected to proceed with VAV ECMO on this patient. And this patient was a little bit more complex, but by day 108, so he was able to at least be awake, sitting on a chair. That is currently the minimal requirement that we have, at least for these patients. So on day 108, double lung transplant, he was transplanted on VAV ECMO, and quickly he was able to be converted to VV ECMO on day 1. On day 3, this patient was decannulated, and today this patient is on post-operative day 41, and he's close to being discharged home. Room air, he's ambulatory now. He's just finishing a round of antibiotics for a respiratory infection. So what is our approach to lung transplant candidacy? So based on what we learned over these cases, and also following what was previously published by Marcelo and Schaff, so I think there's a clear belief that the ideal patient is less than 65 years. There is no comorbidities, or when they're present, they're easily manageable. there should be at least 4 to 6 weeks of onset of respiratory failure. And here is where, whenever we're talking about lung transplantation for COVID, there's a little bit of misunderstanding that we are advocating transplantation for every patient after 4 and 6 weeks. And obviously, this is not real. So I think that the patient needs to check every single of the 10 boxes to be considered an ideal candidate for transplantation. So 2 negative lower respiratory tract samples for COVID by PCR, no evidence of lung recovery. So after 4 to 6 weeks, is still a very high ECMO requirement with no weaning possibility and low lung compliance. And the patient should be awake and interactive on the ideal scenario. So ideally, they should be able to participate on decision making and physical rehabilitation, even though there are several cases in this collective series that we put together that it was not able to get the patient to an awake and completely state that he's participating on decision making. So decision was made on by the fact that the patients were young and healthy before, on wishes discussed with the family, and the next of kin surrogate made a decision. Single organ failure ideally, even though I'm going to show you here that we do have a case of combined organ transplant. Family support is key. Most of these patients are coming from far away. From the 17 patients that we transplanted for COVID now, there's only one patient that was local from Gainesville. All of the others came from far away, out of state, or far away down to South Florida. And obviously, I think this is where a lot of the contraindications lie are on the basic selection criteria for patients for lung transplantation. So severe coronary artery disease, morbid obesity, you see, to us, it was the main barrier to transplantation for these patients to accept a transfer or a recent or current malignancy. And I think that this is the most important one. So you should have signs of chronic advanced lung disease. And a lot of times the surrogates can be imaging, CT scans, signs of a pulmonary hypertension or severe pulmonary hypertension. So when all of these criteria are met, so a multidisciplinary team with expertise in lung transplantation, in recovery after ARDS or ECMO bridge to transplantation, and transplant ID group together to make a decision about listing or not listing. And these are CT scans representative of the cases that we transplanted. So again, the clear traction bronchiectasis, the right ventricular dilation with right atrial dilation. This is the case that I just highlighted for you with clear advanced fibrosis and right ventricular dysfunction as well. And some of the patients are presented with diffuse bullous disease. And a lot of times it is difficult to manage these pneumothoraces. A lot of times the lungs become trapped and the patients develop this low-grade empyema, but I think that doesn't negate a possibility for lung transplantation. And this is our early publication. So the first 12 cases of this collaborative group were published recently. And you can see here a time from ECMO to listing of at least 50 days, and then a time from ECMO to lung transplantation of a median of 55 days. So you see that time was allowed to make sure that these patients were not going to recover on the best available clinical data and evidence possible. And obviously you see that these patients, they tend to be longer in the hospital. So the first case that I showed you, ideal case scenario, patient is ambulatory, the patient was putting on the room as he was waiting for transplantation and walking every day. But on the second case, you can see that he was not able to achieve that state of physical rehabilitation. And then later on, you pay the price. So these patients, they tend to stay 2-3 months in the hospital. So you can see here a median of 80 days. Again, CT scans representative of the cases that we did, on some cases of lung necrosis here with these 12 patients. Obviously, the outcomes are very early, but we saw a 30-day survival of 100%, and 80% of the patients were on room air after a median follow-up of 80 days. So this is the most recent numbers that we put together with this collaborative group. And you can see here 30 cases transplanted from close to 300, so 12% of cases transplanted for COVID in these 5 institutions. And you can see here that we contributed by that time with 11 cases, and as I told you, now we have 17. So the number of transplants ranged from 6% to 25% per institution. And I think what is very important to show here is the deaths on the wait list. So every COVID patient that was listed was transplanted by that time, and we did not see any increase in the deaths on the wait list for these 5 programs that were entertaining or considering lung transplantation for COVID ARDS. And you can see that for most of the programs, the number of patients is small, right? Even though the absolute numbers are higher, they're contributing to less than 15% of the cases. So what about the referrals? As I was mentioning before, obviously the denominator is very large, right? We're not able to accommodate every referral, and what we try to do is screen most of the contraindications early on. We have never transferred the patient from far away that we did not evaluate, list, and transplant. So I think we really try to be aware that bringing a patient from far away here to learn that there is a contraindication, I think is very difficult for the family to understand, and obviously that's going to mean that the patient is going to die. So from 91 referrals, we ended up evaluating and listing and transplanting 12% of these cases. And here you can see these are young patients, average 51 years. 20 patients were declined due to morbid obesity. This was by far the main reason for declination. No financial approval. I think this is what happens when patients, they need to be redirected to other centers, that the insurance that did not approve a transfer from far away, or the patient had to stay locally. And then multi-organ failure, the third most common cause of declination. What about on these 36 patients that we put together, just showing that the outcomes are going to present are reproducible. So again, these are young patients with a median age of 51 years, 22% were female, and you can see that most of these patients are conventional blood types A and O. We had a lot of barriers to transplant patients with blood type B, because lung allocation in the United States still goes by the identical blood type. So these patients, B and AB, tended to wait longer. Obviously, you can see here that lung compliance is in single digits. Most of these patients had a tracheostomy, so 88%. Superimposed infections are very common, and a lot of times by multi-resistant bacteria. And then ECMO, you can see that most all the patients were supported on ECMO on some time, and then 88% of the patients, they were actually bridged to transplantation while still on ECMO. And you can see here, pulmonary hypertension is very common with a mean PA pressure of 45. 61% of the cases have right ventricular dysfunction, and you can see the severity of the cases here with a lung allocation score of 87. Every lung transplant done in COVID patients, in our experience and on this institutional approach, was bilateral through a clamshell incision. You can see here that resizing tends to be common to accommodate the donor lungs in the retracted chest cavity of these recipients. And obviously, the great majority of these patients are transplanted with central venous arterial ECMO. Cases are more complex than the usual transplant, so they're just short of 8 hours from skin to skin. So this is longer than what we usually see, and you can understand here that the transfusion requirements are high, with a mean requirement of PRBCs of 8 units per case, 4 FFPs, and the ischemic time is just short of 6 hours. And most of the programs, I think this is a programmatic decision, elect to continue these patients on VV ECMO post-transplant. They have a higher transfusion requirement. They're more complex cases, so they're kept on VV ECMO post-operatively and decannulated in the ICU. And here are the timelines. So again, I think this is very important to have a closer look here. So these patients, from disease onset to ICU admission, a median of 7 days, a median of 7 days on mechanical ventilation before going on ECMO. And You can see here that from disease onset to transplantation, 84 days, just short of 3 months. And I think that these is the two most important numbers. So 71 days on mechanical ventilation and 55 days on ECMO before being transplanted. And again, I think as we showed with 12 patients, now with 36, our initial findings were just reinforced that these patients, they tend to stay longer on the hospital, 22 days in the ICU, 42 days of a median length of hospital stay. And by the time we had 140 days of follow-up. So what we tend to see in terms of challenges intraoperatively is that these patients, the ones that have the pneumothoraces and the lungs are trapped, I think that the explant pneumonectomy is not so complex in terms of chest wall adhesions, but every hilum was hypervascularized with hypertrophic nodes, and it's hard to determine if was a reflection of the low-grade NPIM, or if this is truly due to COVID or the acute nature of the disease. But you can see that the explant pneumonectomies, they tend to be harder than the usual case, with 66% of cases requiring more than 5 units of PRBCs. I think that the fact that these patients are on VV ECMO when they go to the OR, it's an advantage in terms of not having the lungs being ventilated as you enter the chest cavity. Uh, the fact that the pulmonary hypertension is subacute in these cases, the patients were previously healthy with normal hearts. I think that these RVs are heavily untrained, and hence I think that the high need of veno-arterial ECMO, I think is intuitive to believe that these patients are going to need intraoperative support, and definitely VA ECMO is the best option. And we did have one case of patient that was having right ventricular dysfunction pre-transplant. He was assessed at another institution and transferred to us uh, due to the right ventricular dysfunction. We transplanted him, and his RV essentially did not recover immediately post-transplant, so he was kept on central VA ECMO cannulation. But over 24 hours, we saw significant improvement, and we were able to decannulate this patient. So just understanding that the RV may take a little bit longer to recover, but eventually it does. Complications, the most common was hemothorax, as the explant pneumonectomies in patients that had severe adhesions were more complex. So close to 30% of patients go back to the OR due to bleeding. You have a 16% cases of acute kidney injury with need for CVVH, and 11% or 4 cases of DVT. And then obviously prolonged weaning due to deconditioning is very common. So the median time on mechanical ventilation after transplant of 14 days, I think just shows that these patients, a lot of times they're not on that ideal state of pre-transplant conditioning. But what we did is that we kept them as good as we could before proceeding to transplantation. And there were 2 deaths in this series, one from Milan on a patient with a critical illness polyneuropathy. They developed psychiatric issues and Klebsiella pneumonia sepsis lately. And then a liver failure with secondary sclerosis and cholangitis on a patient in Vienna. It was discussed at some point, liver transplantation, but never proceeded to. Pathology findings, you can see here that fibrotic changes are obviously the most common in 72% of the cases. Diffuse alveolar damage is present in more than half of the cases. And as we are learning more and more, there's a lot of vascular changes in patients with COVID. Most of these changes were medium or small vessel thrombi, and a lot of pulmonary alveolar hemorrhage and infarction, and the bullous form of disease that I showed you on one of the CT scans. And here is these are the results. So you can see here that by 30 days, all of the patients were alive. The deaths were later after the 1 month mark. By 30 days, the patients had a mean Karnofsky performance status of 60, with 30% of them still requiring supplemental oxygen. But as more follow-up was acquired, you can see here that the Karnofsky performance status improved from 60 to 80, and now all patients by 3 months were on room air. And again, we had those 2 deaths. We have more and more of these patients now reaching 3 months survival, and we're putting a publication together. And can we expand further? So can can we or should we consider combined thoracic and abdominal organ transplant for these patients? So this was a difficult case that we had a patient with a 54-year-old male with shortness of breath, hypoxemia, and acute kidney injury. He was admitted, and by day 7, he was placed on mechanical ventilation. He already had acute kidney failure by that time, a requirement of CVVH. And by day 11, that patient was cannulated on VV ECMO. This patient is the only patient that we transplanted that was from Gainesville. And you can see here that over a period of 2 months, there were no signs of lung recovery. What is really striking is that this patient had a BMI of 38, and we would not consider transplantation for him. But this patient, over the course of close to 3 months, his BMI got down to 32. The patient was heavily motivated, and these are the imaging findings. So you can see here the latest chest X-ray. You can see the clear traction bronchiectasis and fibrosis on these cases with still some ground glass opacities, and the pulmonary hypertension with moderate right ventricular dysfunction with a TAPSE of 13. So we elected to list this patient for a combined double lung kidney transplant. There were a lot of discussions if you should do that or if you shouldn't do that. This patient was previously healthy, uh, had no issues, and he was heavily motivated. He was the father of 10, a lot of family support. So this patient was transplanted. We were able to get this patient with a good physical rehabilitation state. So he was weaned from ECMO on day 2. He was weaned from mechanical ventilation on day 5. He had a very challenging post-operative course due to acute antibody-mediated rejection, but he eventually recovered. He's now PFTs on 5 months, FEV1 of 51%, creatinine is 1.4. He's on room air, getting stronger. So what are the lessons learned from this experience of with 17 cases and also the reproducibility of the 36 cases that we were able to put on this multi-institutional experience is that I think it's key to rule out absolute contraindications before transferring the patients. They most of the times are going to come from far away, since I don't think there's going to be a widespread adoption of lung transplant for COVID, for especially for the sickest, most complex cases. I think that whenever possible, we try to perform the evaluation and initiate the physical rehabilitation remotely when the physicians are very collaborative and it's possible. That's what we try to do. I think to us is very, very striking the ability of patients that became acutely frail, but were previously healthy. They have been sedated and paralyzed for weeks to be rehabilitated. I think this is something that we are learning now, and we didn't think it was possible. I think the majority of patients we experienced in this series, they were offered at some point withdrawal of life-sustaining therapies. They were told that they were going to die more than once. Their family members became desperate and started to look for potential transplant centers that could accept them, because I think the notion that transplantation can be performed for these patients, it is still not widespread in the medical community. And I think what we learn a lot, especially regionally in United States as a country, there's an urgent need to standardize ECMO care. We're still seeing places that by 14 days, no lung recovery, ECMO is withdrawn. We're still seeing cases that the ECMO is being considered to be withdrawn because the patient cannot be anticoagulated, and the sedation and paralysis on ECMO is something that really most of our patients struggled, and we had to have them admitted for an additional month or 2 just to get them to a point where they could be rehabilitated. So in conclusion, lung transplantation is a viable life-saving option for patients suffering from COVID-19 ARDS that fail to present with native lung recovery. I think remembering that native lung recovery is always better, but if that's not possible and it's clear that the disease is irreversible, I think transplantation is a very viable option. I think that obviously it needs to be understood that these are very well selected patients, and I think that all of these centers, they have a setup where the ECMO program and the lung transplant program are together. So understanding and managing these patients and understanding when to transition from bridge to lung recovery, to bridge to lung transplantation, I think is very important. And I don't think that's very clear in places that either don't do bridge to recovery or they either don't do bridge to transplantation. And I think obviously we're going to follow these patients very closely because long-term outcomes are going to be key to help us standardize indications and understand timing for referral. So these are just some of the patients that we transplanted. And I think, again, there's no statistical model saying that there's a survival benefit, but every patient would be dead today if we didn't tell the referring physician that they would be a transplant candidate. So this patient here, 6 months in the ICU on mechanical ventilation, until he reached the family reached out to us and we transplanted him. This is a nurse that was transferred to us, and we were very early on. After 1 month of ECMO, they started considering transfer for a place that could actively rehabilitate the patient. And by 2 months, she never showed any lung recovery and being discharged here. And this is a patient that was evaluated and listed at another institution, developed RV dysfunction, was delisted, and was offered withdrawal of life-sustaining therapies until the family reached out to us. And this is him after transplant at home for Christmas. So obviously this takes a village. It's not a work of one person. I think having everyone in your team, from the person that opens the door in the ICU to the whole nursing team, ECMO specialists, respiratory therapists, critical care physicians, pulmonologists, I think is very important. Having everyone understanding where you want to get, why we're doing that, and what are we trying to accomplish together. And I think that it's clear to me that with these cases, the 17 cases that we've done so far, when they really understand what we are able to pull together, seeing these patients that are on the verge of dying, leaving the hospital on room air, I think that really creates a strong connection and reinforces that understanding of why we're doing that and how come these patients are so sick coming here and we are considering transplantation for them. So once again, it's a great honor to be here. Thank you for the invitation, and I'm happy to answer any questions.
Thank you very much, Tiago, for an excellent presentation. It was very, very eye-opening, and congratulations on your leading edge innovation and excellent results. We've been talking about this for quite a while, so I'd like to open the floor for questions. Marcelo?
Yeah, sorry, I don't know how to raise the hand on Zoom here. Maybe I need a Zoom lecture.
That's right.
Congratulations again, Tiago. This is a really amazing achievement, not only this year, but all the years you've been there, and to create this amazing program. I think my question to you is, of course, our experience is much smaller here. We've done 3 patients, but one of the remarkable things we're seeing is that, these patients, they seem to recover, at least in our experience, for someone that was in an ICU for 3 months, a lot faster than a chronic lung disease patient that had been, for example, on ECMO as a bridge to transplant, or so on and so forth. So, I think this is relevant as, even when COVID finishes, but we still will continue to have ARDS, right? And influenza and other patients that we've seen in the past that stays, months on ECMO without lung recovery. So how do you see, transplantation for ARDS coming up in the future? And to follow on that is, has been also any discussions within your team from the ethical perspective, of, why transplanting, these patients which will have a very high LAS score, versus your patients in the, chronic lung disease on the wait list,
Thank you, Marcelo. Yeah, I think that for the, let's start with your second question. I think this consideration for transplant for COVID is something that evolved with time. So I think we started to get a lot of potential referrals by April, May, June. So we did the first transplant in July. So April, May, June, a lot of referrals of potential cases, and we just started discussing that as a program that embarked on transplanting patients, for instance, on acute and chronic ILD exacerbation, uh, uh, use of ECMO as bridge to transplant. I think we should entertain that. I think the pieces to pull a lung transplant for COVID into a successful state were there. But obviously, I don't think that the adoption was across the board. Everyone was heavily favorable to that. I think that what is interesting on one hand in the United States is that the lungs are allocated based on disease severity and expected outcomes, right? So we knew that extrapolating what we had in terms of a disease severity, these patients will be very high LAS, but we didn't know about the post-transplant outcome, right? If it's going to be favorable or not. But I think that with several discussions that we had as a group on why we were going to do this, why would we entertain that, and also on a stepwise manner. So you see that the first case that we transplanted was a perfect patient. It was 3 months on ECMO, walking in the unit with lungs that they were never going to recover. I think that putting that on a stepwise way, that we're going to essentially every transplant that we're going to do, we're going to review together as a group. And let's say the first 5 cases, first 10 cases, and then slowly pushing to higher severity cases, pushing to getting patients that were sedated and paralyzed for several weeks here. So we would see if we were able to rehabilitate them and get to a transplant state, or even revisiting that idea that we will only transplant patients that are ambulatory, to know now we're going to maybe consider patients that they reach what we feel and our physical therapy team feels is the maximum rehab potential with those lungs, and now they're getting to life-threatening complications, bacteremia, and so on. I think that was very important, and I think that as we started to do more and more, that the acceptance of those team members that were not completely on board with the idea increased. And I think that by today, I think we really think as a whole team going on the same direction. I don't think that those hesitations are there anymore. And then for your first, I think comment, I think the COVID, I think no one asked COVID to be here. Obviously, we all want this to go away and never transplant COVID patients again. But I think it's really opening our eyes to what is possible to do with acute respiratory failure, right? If we all looked, at least in our program here, if you look back on a patient that had been on mechanical ventilation or ECMO for 1.5 months, that is sedated, not awake, and they were considering transferring this patient to us for potential transplant, I mean, we wouldn't even open the chart. There will be a no, we were not going to consider, because this patient cannot be rehabilitated 45, 60 days on the ventilator, sedated and paralyzed. And I think that this is showing that these patients, that they're not chronically sick, but they develop this acute state of advanced lung disease and frailty. I think that their capability to recover is very different. We're not talking about the same disease. We're not talking about the same expected recovery that we are used to see when we transplant 99% of our patients with chronic lung disease or some acute on chronic lung disease. I think that this is a completely different beast, and COVID is opening the door for these patients, that they will die from ARDS with an unwinnable state, and until recently they were just withdrawn support and allowed to pass.
Thank you. So Atul, and then Tom, and then Leanne.
Oh, thank you. Yeah, thank you, Tiago. That was wonderful, wonderful work. Congratulations. So I'm just curious if you could comment a little bit more on the informed consent process in the patients that were not awake and able to give informed consent. Like when they woke up with a lung transplant, like what was their reaction, and how did they feel about it? Were there any that decided afterwards that, oh, you shouldn't have done that? And I'm just curious how you approach that.
I think that's I think important aspect too. I think we have not ourselves transplanted patients that were essentially not completely awake, but we would consider that. We did have cases from the Vienna series and Northwestern series that were transplanted on that situation. And in those cases, the decision was made based on the wishes of the patients before going on mechanical ventilation and ECMO. The fact that they were all young patients and previously healthy, and the decision was made by family. But what I can tell you in terms of what we see here with our patients, I think that every single patient that was transferred here, just the fact that we transferred them for a potential transplant for them, I think that just this little hope that was infused in the family and on the patients, I think that was already life changing. Every patient came to us and said, "Thank you so much for accepting my case. I know that they tried to call the whole country and until we find you, everyone said no. Just the fact that we know that this may be a possibility and is being looked at is already a blessing to us." So I think that this just speaks to, I think that there are these barriers of let's say, patients that are not awake or making a decision on the patient end. But I think obviously we need to put that into perspective, that all of these patients will be dead without that option. And I think that the fact that these are all healthy young patients, I think it's a very different situation than patients that are chronically sick and they say that they don't want to be on a ventilator or they don't want to be on ECMO. But these are healthy patients that most of them have a family to raise. They have a lot of things to accomplish in life. And before going into mechanical ventilation, it is clear that they make their wishes very, very boldly, that they, whatever needs to be done to keep them alive, that's what they want.
Great, thanks. Leanne's question was much the same about the consent issue, which is what we find very difficult. I also wanted to say this is a really important discussion for our team, so we can go a few minutes longer. So whoever can stay, please feel welcome to continue the discussion. Tom, your question?
Yeah, thank you. I also thought that was a fantastic talk, Tiago, and I especially like the way that you spend a lot of time talking about the context that existed prior to the COVID experience in transplant, but also in the ECMO program. And so my question is really about the ECMO management, and maybe this is micro detail for many, but you know, for both consenting and for rehabilitation, it's obviously important to get the patient in the best possible state, and it sounds like you've done a great job. And my observation is that one of the critical steps is when patients are well supported on VV ECMO, but then when you start to wake them up and reverse the sedation and the paralysis, we have problems with hypoxemia. And it sounds like you've had experience where patients weren't perfect on ECMO, but then have been able to get past that point. What are some pearls of wisdom you've learned at that point?
I think a lot of thanks, Tom, for your comment. I think a lot of the let's say ECMO management was related to exactly getting the patients awake. So we did spend, there were patients that were with us for 30 to 45, 60 days with us just to get them to being a potential transplant candidate, that we spent to get them awake and get them with some degree of physical rehabilitation, being able to sit on a chair. I think that one thing that it was clear to us is that a lot of these patients were coming with a dual lumen single cannula. And whenever we started to become limited by the amount of flow that those cannulas could provide to these patients, I think that not hesitating much and upsizing the cannulas, going to 2 ECMO, 2 cannula ECMO, VV ECMO, I think it was clear to us that, and I think that that case of VAV ECMO illustrates that. The other aspect that I think is important is the transition of sedation, right? The sedation, when these patients get to us 1-2 months sedated, it was extremely challenging to get them just to be awake and comfortable. So transitioning a lot of the sedation medications, what our pulmonary and critical care team does a lot is transitioning a lot of these medications to medications by the Dobov tube. And I think that they had been successful on weaning sedation, midazolam, opioids from that IV route to Dobov tube, and keeping the patients more awake and accepting the hypoxemia. So a lot of times we had patients that were with saturations in the 75, 80%, but as long as those patients were essentially awake, trying to communicate that there's no signs of end organ damage, lactate was normal, I think we all agreed that we were going to accept a lower O2 sats on those patients. We may not get to the perfect spot, but at least to an acceptable one. So these were a little bit of the let's say details that we used to have these patients. I think that to me, I think having physical therapy, occupational therapy on board with heavily motivated people that have been working with us for 2-3 years now and are all pro mobilization of these patients is also very important. As we started to transfer more patients, what we discussed with our hospital is that to get these patients to a transplant state takes a long time. So we asked them to essentially double the efforts of physical therapy available in our unit, and the hospital understood that there was a way to get patients that could stay months on ECMO before being listed. I think that that was very helpful as well.
Tiago, did you, I'm not sure if I missed it, but did you transfer any patients in on ECMO that you ended up not listing? And how did you handle that?
So we did transfer patients that we did not list for transplant, but what happened is that the number is very small. We had 2 cases that we transferred to us and the patients recovered. So the patients, they were sedated, paralyzed, and on ECMO. This is essentially poor ECMO management. So we essentially rehabilitated these patients for possible transplant, but the transplant was never needed, right? And we did have one patient that we did not transfer from outside, but we cannulated, and this patient was an ideal transplant candidate, was being supported by VAV ECMO for close to 3 months, and we were going to list him, but what happened is that he had a huge ulcer from the from the fecal control system, and he started to have repeated bleeding with coagulopathy, and that patient ended up dying. So but transfers that we accepted from outside that we did not list or transplant, but they died, that didn't happen.
And I think I see some of our ICU people are on, Eddie and others, maybe we could comment, but I do think our biggest struggle is the issue of getting the patients awake. And we tend to have them paralyzed and sedated for a long time. And I'm just wondering about, like, sometimes when we try to wake them, there's either agitation or there's the concern about the work of breathing being exerted by the patient. I mean, do you have those discussions of, or is that just inadequate ECMO support that we should be going to the VAV mode, or what should we be doing so that the trigger isn't just give them more sedation again and paralysis?
Yeah, I think this is a big problem, this vicious cycle of trying to wake the patient up. And patients that had been on sedation for a long time, invariably, we saw this pattern of air hunger, if you will. But I think that after the first 5 cases, we really sat with our ICU nurses, with our critical care team, and we kind of understood that there were going to be moments that we all felt very uncomfortable, that the patient was breathing over the vent by several cycles, that it felt like the patient was not being well supported, but all the numbers, all the monitoring was showing the opposite. So I think that this understanding that there will be moments that the family and the physicians and the nurses are going to be very uncomfortable with the way that the patient is looking, but we're going to try to do that in a stepwise way, a little bit more by every day until we get to a point where the patient is communicating and is comfortable sitting on the chair. I think that understanding was very important. And that's what we did. There were patients that we had literally to go in the room every 10, 15 minutes, the critical care physician, to talk to the nurse and say, hey, I mean, what we're trying to do here is this. If this patient doesn't get to this point, he's going to be stuck and we won't be able to transplant.
If I can just comment on that. I know Cecilia has a question, but my comment is at the same topic. I think it also goes to the, I think Tiago can comment, but you didn't have like 30 patients on ECMO at a given time, okay? And I think when you have this number of ECMO patients too, a lot of the things become automated and you don't have that relatively small committed team, that is saying, okay, the patient is desatting, but that's okay to accept at this point because the patient is doing physio or waking up and so on, versus the natural response is not even done by the physician, but even the nurse at the bedside see the patients, desaturating to 88, and then the natural response is sedation, right? So I think it's easier to manage. I think if you have a more, I would say, dedicated team along that objective.
I think so. I think that's the kind of thing that maybe we need to pay some more attention to in terms of education sessions with the intensivists and nurses and RTs and everybody to sort of move a little bit more to that mode of being able to awaken the patients. I think that'll also decrease some of our anxiety about the consent issue of the patients. Cecilia, you had a comment?
Thank you. Excellent talk, Tiago. It was really amazing to show us that experience. We are, as you heard, just starting, so we have done 3 patients. But I was looking more into the patient side. So I don't know how big was your transplant list before this all came on, and how many patients you actually have transplanted, and what are the patients that are waiting for a transplant, like thinking about this. So Marcelo mentioned briefly about that. But we have patients commenting to us that, well, what is the chances that I'm going to be transplanted if you are now doing COVID patients? And again, we haven't done really many, but that is what people think. And as you were saying, these patients that you brought to the transplant with COVID, they have that hope only, and every family is very appreciative about doing that. But our patients also get sicker over time. They relocate. They are really preparing to be good candidates to be transplanted and being here. So how did you approach that if you have to do that? Because we have really been facing that, and maybe people being discouraged about what is going to happen while they are here, seeing, of course, that the number of donors is less and that the time waiting is being longer.
Mm-hmm. Yeah, that's I think a very pressing issue, Cecilia. I think we did not get into any discussions of patients complaining about consideration of transplant for COVID. I think whenever the discussion is coming within like our team members or nursing or coordinators, I think what we are seeing today is that transplantation for COVID is about 10-15% of our cases. So I don't see that getting to a point where it's going to be half of our transplants being performed for COVID, or even like 30-40%. So I think number one, the understanding that that is going to be a relatively small, well-selected number of patients is important. And I think that the second one is the way that the lungs are allocated. So the understanding that the lung allocation score is meant to prioritize patients by disease severity. So I think that that's another thing that as we build the data on post-transplant survival, I think that that's going to be important to recalibrate that. But we know that without a transplant, those patients would be dead. So I think that there's not much of we didn't feel any bigger discussions. We continue to monitor our wait list mortality, which I showed you did not change much. But I really do think that closing the door for these patients is not the answer, right? I think we're going to have to adapt as a transplant community. I don't think every transplant program is going to be doing that, but programs that are used to bridge patients with ECMO that have acceptable wait list mortality, that can be more creative and aggressive on the donor end, I think are the ones that should be entertaining that and continuously monitoring if that's having any negative impact on their, let's say, conventional patients waiting or not. But again, I do think that this is something that we probably are going to see more often, is patients with acute lung disease that are now being supported on ECMO for long times and are not being weaned. So I do think we'll have to adapt, and I don't think that saying no to these patients is going to be the answer.
Thanks. Eddie had a comment.
Yeah, thanks, Jeff. Hi, Tiago. Fantastic talk. Thanks for sharing your experience, and congratulations to you and your program for such amazing work. I think your points there, Tiago, are really good from our perspective. I think sort of hearing your struggles, which are our struggles of waking these patients up and that taking sometimes days to weeks to occur. There's going to be that difficult transition to enteral sedation you mentioned through the drop-off from IV. And recognizing as a team that there's going to be those challenging moments where patients will see dyspneic or accepting lower saturation. This is going to be an important, I think, learning from your experience and your comments, a culture shift for ICU. I think you probably remember when you were here as a fellow, we were maybe just making that culture shift of mobilizing ECMO patients, which many thought was impossible. I remember one of our senior perfusionists saying to me when I said we could mobilize this influenza patient like other centers had, and she mentioned, I'd been a perfusionist for 20 years, and if you think you can mobilize an ICU patient, that's the craziest idea I've ever heard of in my career. So I appreciate your comments about the sedation, accepting lower saturation. This will be a culture change for us and an important one, and would be fantastic to learn from you and your team so we could also make that transition. Because to me, as Shaf mentioned, like I don't understand, we see this in ILD patients, when they have good gases on ECMO, they're still dyspneic, they're still tachypnic because of their intrinsic lung disease. It sort of doesn't make sense to me that we think we'd wake up a patient who has a CT scan, like some of the patients that you showed, and they would be breathing 16. They're going to be tachypnic. They're going to be air hungry. And I think understanding that the larger goal to get them out of this situation is through this difficult period, I think that's something that we'll need to work on. So thank you for sharing your experience.
Thanks, Eddie. There's someone with a T number. I don't have a name that has a question.
Oh, it's me. Thanks very much, Tiago. It was a great talk, and congratulations on the work. I wondered about how you are assessing the reversibility of the lung disease. And I thought your first case was particularly striking. And I mean, you covered it to some extent, but it seemed like you were incorporating right ventricular dysfunction into that assessment. And I was wondering about the validity of that premise, or where that comes from. I appreciate there's also the trajectory and the CT imaging.
Thank you, Matt. I think a lot of the decision making is around the CT scan findings. So seeing fibrosis or traction bronchiectasis that may point for more like a chronicity of the disease is what we're using. And the right ventricular dysfunction, I think a lot of what we use is that as a marker of disease severity, because in our experience, patients that we had not on the transplant end, or they were being bridged to recovery, a lot of these patients, we started to lose control when the right ventricle started to go down. So it was not uncommon to us to attempt to rescue these patients with a conversion to VAV ECMO, and these patients eventually never come back and die. So this monitoring of the RV is mostly to make sure that we're not losing control in terms of the disease severity. Let's say if the patient with early signs of chronic lung disease now is starting to present with severe RV dysfunction, I think it's intuitive to believe that that patient is on the wrong trajectory of recovery and is probably going to die. So obviously, I don't think there is a very, let's say, today evidence-based irreversibility determination. I think we are working on that with our radiologists, trying to put together patients that indeed went to transplantation and patients that recovered, to see if we can find a marker over there. Ankit Bharat is looking at flow cytometry for alveolar cells to see if he can find a marker for that. I don't think we have that yet, but I think that hopefully with more awareness that transplantation is possible, I think more data is going to come to validate what we're doing, or to show that maybe we're pulling the trigger too early, which I don't believe.
Tiago, with respect to the RV dysfunction, I think it's a really important realization that this isn't like chronic lung disease and the RV is not trained. When you see that, you showed where you switched to VAV. A lot of RVs get better when you improve the oxygenation acutely, but have you chosen to go on the Protec duo cannula up front, or switch to that when you see an RV that's suffering?
That's a great point, Shaf. I think unfortunately most of the patients that come to us, they are already cannulated, and we don't have much experience with the Protec duo. I think I heard from Marcelo and some cases from Anki that seems to be a really positive way to support these patients and prevent the need for VAV ECMO. But we did not consider that as of now. There has been discussions. I think that probably that's a great option.
Yeah, I mean, it's tricky, and as Marcelo probably explained to you, when we had someone right IJ cannulated, we switched it to the left IJ and then put the Protec in through the right. I mean, a little tricky to do with pump sucking and a completely dependent patient, but it really helped with the RV recovery. And I was just thinking about, should we be using that more often when you see a big RV on the patient that's, you know, failing ventilation in your first go at ECMO? So we're sort of exploring that a bit more.
I think that may be a great option.
Are there any other questions from anyone? I don't see any others. Well, thank you for staying late, everybody, and especially you, Tiago. That was a fantastic presentation, and we learned a lot. And congratulations on your incredible success, not only in the COVID patients, but also in your whole transplant program and ECMO programs. You've achieved a remarkable success that we're proud to call Toronto South, and even better.
Thank you so much. It was a great honor to be here, and it was great to see all of you.
Great.
Great. Thanks.
Thanks.
Bye.
Thanks. Have a good day.